Good evening to all of you from all over the world. It's a true pleasure to introduce Dr. Lukas Kirchmair. He is a highly experienced anesthesiologist and serves as lead flight physician at the HEMS base in the famous Kitzbühel region, one of the most iconic alpine area in Austria. Since the late 90s, he has also been a dedicated instructor at the ESRA Innsbruck Cadaver Workshop, sharing his experience with passion and commitment. In his daily work, he cares for critically ill and injured patients, often in challenging pre-hospital environments, bringing both skill and calm to the most demanding situation. In today's webinar, organized by our partner PAJUNK, he will share key application and clinical insights that you can apply in your daily practice. Feel free to submit your question using the Q&A section rather than the chat, and enjoy the session. We will try to answer your question at the end of the webinar.
Thank you, Beatrice, for your kind words. I'm already following the chat and I'm very, very surprised and I feel deeply honored. There are really people from all over the world listening to this webinar. So it makes me a bit of kind of nervous. So, dear colleagues, it's my greatest pleasure to have you here this evening in Europe. I hope for those who come from Europe, you don't have a too hard day today. And yeah, let's use the next 45 minutes to talk about the topic of pre-hospital nerve blocks. And a little bit I tailored the webinar more to the topic of pre-hospital blocks because the critical care settings it's an ongoing process from pre-hospital regional anesthesia to acute trauma care in an ICU, and we can discuss things later on. But now I would like to use the time to discuss and focus on the pre-hospital blocks. So now I need to share my screen. Okay. So, does this work, Beatrice? Sorry, I don't know why I can't see it now. Is my screen shared right now? I can't hear you. Sorry. We trained that.
You have to go down.
Yeah. But there we are.
Okay, perfect.
Yeah, here we are. So let's start from the beginning. There we go. So, okay. So this is my talk for this webinar, Regional Anesthesia in Emergency Medicine. I have not many conflicts of interest so far, but I receive lecture fees from PAJUNK for other training and educational activities. So this is the place where I work. We are a medium-sized community-based hospital in a small city 20 kilometers east from Innsbruck. I'm sharing a department with a little bit less than 20 doctors, and most of our patients are trauma and orthopedic ones, general surgery, a bit of obstetrics and gynecology. So that's our daily base of work. And beside that, I am responsible for a ham space, which is located in the Alps in near Kitzbühel, right by Kitzbühel. And to give you a bit of teaser and to wake you up a little bit, I brought a short video clip to give you some impressions what pre-hospital work means for us and what Austrian area rescue systems work like and look like. Just a few seconds, and then we go on. Okay, so this is where we practice emergency medicine on our ham space. Maybe some of you work in a place like this, for example, the colleagues from Switzerland or from Germany, especially southern Bavaria or northern Italy, where also are highly trained and well-equipped ham systems are in place. So my agenda for the next 30 to 40 minutes is let's talk about pre-hospital analgesia. What is the current status? And then proceed to the pre-hospital blocks on an emergency medical system. It must not be a helicopter emergency medical system, but it's also the same rationale for ground-based systems. What is the current status and evidence? And of course, there are areas of concern and ongoing discussion. And then let me summarize and give you some perspectives on that. So in general, when we talk about our system, it's very important to emphasize that the Austrian emergency medical systems are all physician staffed, which is the same for Germany, for Switzerland, and for Italy. So when the competences for paramedics differ between European countries significantly, but maybe we find some discussion on that later. We all agree that analgesia is essential in human casualties and remains one of our core responsibilities in pre-hospital care. And as you can imagine from the short video clip, from the teaser, and from the pictures I already show you, that we are working in some difficult environment, but that means that analgesia always remains essential, but sometimes our possibilities are limited and must be tailored to the rescue mission, to extrication and retrieval, for example. So pre-hospital analgesia is mostly for trauma patients. We know that from statistics, most injuries, they affect limbs, causing fractures, soft tissue injuries, and which is also very, very painful, joint dislocations. Common injuries are therefore dislocated shoulders, so humerus fractures, forearm and wrist fractures, fractured hips, as well as femur fractures and other parts of lower leg fractures and ankle fractures. They can be open, they can be dislocated, so we see all kinds of injuries, especially in the mountain areas where an increasing amount of people is playing around for leisure activities, for mountain sports, and also now in different daytimes. It can be in the day, in the morning, in the evening, and also in the night. So people are very active, and this is also sometimes a result of tourism and also of over-tourism. We should not forget that. So this is what we have. This is our armamentarium. These are our standard IV analgesics. It's fentanyl, it's morphine for some other conditions, and ketamine. And we do have metamizole for some surgical conditions. Sometimes people need non-opioids for some, let me say, abdominal pain or something like this. So we have a very limited capacity of weight. Every piece of equipment we carry with us must be taken into account that this just increases the weight of the load of the aircraft and even the weight of our backpack we need to carry when we go outside and do missions in the environment. So fentanyl is one of our most used opioid in emergency medicine in our system. It shows a rapid onset, but it needs clinical experience to give the right dose, to use it in the right situation. And of course, it has side effects. It can cause sedation, hypotension, nausea, and vomiting, which especially sometimes is a problem during flight missions if people are suffering from motion sickness. This will worsening tremendously during flight operations after they have received strong opioids. It can cause respiratory depression, which is not so common seen if we give fentanyl, as you all know, in a patient with severe pain, but in some retrieval situations, respiratory depression might be a problem. And we see complications sometimes during extrication. I would like to emphasize on one very important point, and that is that during some of the retrieval missions and during extrication, we only have very, very limited access to the patient. So we place the patient in these rescue bags. We have vacuum beds to position the patient. And during that phase of the mission, there is very limited access for us. So if a patient is under deep sedation or we have received a large dose of opioids, this can be sometimes a problem, and our time and space for action is very, very limited. Esketamine. Esketamine is commonly used for extrications, for reductions, and for these purposes, it's really a great drug. We see stable hemodynamics, as you all know. Respiration is preserved, but of course we see side effects. And the side effects in this case are sometimes very, 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 very awkward. Bad dreams, patient report about very bad dreams, hallucinations, some show psychotic reactions, even agitation. And of course, this can also result in complications during retrieval and during flight when patients are very agitated in the cabin, where space is also very limited. And in my view, that's what we also see in our hospital. Ketamine is great for the emergency physician outside, for the rescue crew, because they have the patient perfectly pain-free for about 10 minutes or 50 minutes. But when the patient gets back to consciousness, then these hallucinations are really a problem, and psychotic reactions, which is sometimes more a problem in the hospital than during the emergency medical care. We have alternatives, of course, when we don't get IV access. We have this ketamine midazolam nasal spray, or we use the MAD. And in Austria, the mountain rescue teams, they are equipped with these methoxyfuran whistles, which can sometimes really be of great value in providing analgesia. They are a bit of sedative, and it can be used by paramedics with great success, and they use it commonly on mountain rescue missions when there is no doctor available at that time. So this is a common situation. Yeah, looks very nice. This is a closed dislocated ankle fracture, and this needs urgent reduction. There is no discussion. This is straightforward, and this is a standard situation where we use a combination of midazolam and ketamine to have the patient asleep for a few minutes, and then do the reduction and place the leg in this SEM splint and fix it there, and then get the patient back to hospital. And then now let's get into the topic of pre-hospital nerve blocks. And this is a very nice case report I received from a colleague from our system. And he was an emergency physician outside in the field, and he had to treat the patient with a 3rd-degree open forearm fracture. The patient received 50 milligrams of ketamine and 5 milligrams midazolam, which is already a significant dose of ketamine and benzodiazepine, but the patient still was in severe pain, more than 7 on the NRS, which is absolutely unacceptable for a physician-staffed system. And so that the colleague decided to do an axillary plexus block with 18 mils of 2% lidocaine. And what you see in this handwritten document, that was well documented. He wrote down, because this is what we discuss at the end of the talk. There was the dose of ketamine, dose of midazolam, and that the analgesics, they were not enough. And then he did the plexus block. And what he also documented, there were no signs of nerve injury prior to the block, which is very important, that we do a good documentation and then a good handover to the hospital. So this patient was successfully treated in the field with an axillary plexus block. But pre-hospital analgesia is still a significant problem. Eric Albrecht from Switzerland performed a nice study more than 10 years ago, and what they found, and this is still a problem, that there is a significant undertreatment of pain by emergency physician, that between 1/3 and 2/3 of patients report significant and severe pain outside in the field. And they call it the problem of oligoanalgesia. And interestingly, even in one system, they found a huge variation among physicians. And interestingly, what I call is a gender pain gap. That doesn't mean that female patients, there's a difference between female and male patients in the perception of pain, but female doctors, interestingly, were less aggressive in their pain management outside. Maybe this is some male behavior that we approach patients more aggressive. And this, interestingly, this resulted in a, don't let me say better quality, but in a larger amount of analgesics that were given outside. And moreover, and this makes it even worse, was the finding that the higher the pain scores are, the lesser is the amount of patient or the percentage of or the proportion of patients with unachieved analgesia. So the green field in these bars here, this is means NRS 4, 5, 6, 7, 8, 9, 10. So at an NRS of 10, patients showed the highest percentage of unachieved analgesia. What does that mean? The higher is the pain, the lesser is the efficacy of pre-hospital analgesia. The lesser is the pain, the higher is the percentage of patients without the so-called oligoanalgesia. So there is an ongoing problem with severe pain during emergency medical treatment outside. And this is a nice graph from the same study. And what they showed in the study were 77 physicians included. So each bar, each vertical bar or column represents one physician. And what you see on the very right hand side of that graph, that this is one physician in that period who treated approximately 55 patients, but the higher caseload physicians have, the better is the quality of analgesia, which is just a matter of experience, which seems absolute logic to us. No question on that. Now let's go to the pre-hospital blocks on a HAM system or on an emergency medical system. It must not be a helicopter-based system, also ground-based systems do blocks. So ultrasound, where does it come from? Or the idea originated on the basis that ultrasound-guided regional blocks are now widely implemented in hospitals all over the world, as well as already in emergency departments. Nerve blocks, they provide an optimal analgesia in acute trauma. This has been shown for fractures, especially for hip fractures, dislocations, and also for severe chest trauma. What is the rationale for pre-hospital blocks on an emergency medical system? Most of the systems are now all equipped with pre-hospital ultrasound. And for many countries, this is also true for Austria and for many other countries, that many doctors or most doctors are already trained anesthesiologists or intensivists. And pre-hospital blocks have been shown to be feasible and safe overall. And what is the biggest advantage for us is that pre-hospital blocks, that they show optimal analgesia for extrication and retrieval, where I already tried to show you that there is limited access to patients during that phase of a rescue mission, and we have no cardiovascular and respiratory side effects. And this was an absolute game changer. I don't get any money from the company, but we have this machine or this device in service now for approximately 2 years. And we had another mobile handy device before, but this was a huge step forward in image quality, in durability, in battery performance, and even in performance outside in the field under extreme conditions. We do missions in winter when we have temperatures below zero, sometimes below 10, below minus 10 degrees, minus 15 degrees, which means that also our equipment is under severe stress. So this was a big step forward for me in doing the blocks outside in the field. But and this was a case I did yesterday. Yesterday I was on the helicopter, and we were called to an 80-year-old lady. She fell out of her bed during the night. She had a fractured hip on her right side, severe pain. She was just lying beneath the cupboard here, and the bed was on that side. She had obviously a fractured hip, and we did a femoral nerve block straightforward to get her out of her bedroom and transfer her to the hospital. This is quite straightforward. We have normal conditions as we have it, not the same as, but like in our hospitals, we have light, we have a normal room temperature, patient positioning is not that problem. We have good patient access normally, and we can expose the patient to a normal room temperature. So this is quite straightforward. We have the monitor here in place. We have the ultrasound machine and IV access. So we meet all the requirements. And this is what we did in one of the workshops last year. It was at the German RAC. Maybe some of you have been there. This was a big German conference on regional anesthesia. And I was in one of the sessions on blocks in emergency medicine, and try to do that in your hospital. Try to do scanning when a patient or your model is lying on the floor. This is a complete different situation. Try scanning when somebody is lying on the floor and you also operating on the floor. This is completely different. And we trained that, and this was a great experience for all of the delegates. And we also got some new ideas how to position, where to place the machine, etc., etc. And this is a complete different scenario. This is outside. This was in snow. This was in winter. At the end of day, it was getting nearly dark. So sunlight was the sun. It was after sunset. So if you do these things outside, you have sometimes difficult light conditions. It can be dark or it can be very light. Sun is shining on the screen. We have different weather conditions and temperatures. There is dust outside. There is dirt, snow, ice, and it's sometimes necessary to expose a patient to do a block. In this case, it was not difficult. The patient received a left-sided interscalene block for a dislocated shoulder, which was very, very painful in that case, and there was no chance to get the patient away from that place where he was injured. He was a skier. Last descent, it always happens at the last descent. The helicopter was 300 or 400 meters away, and we needed to carry him to the aircraft, which was indeed at that time, and in this location also a challenge. So technical and electronic equipment sometimes comes to the edge, and it is not rare that medication starts to freeze. The ultrasound gel starts to freeze. So time outside, especially in winter, should be kept as short as possible. We will discuss that hygiene requirements. So those who are watching careful see that I am not wearing any gloves. But the reason was very simple. We had many missions on that day and we ran out of gloves. But we will discuss that later on. And time is always against us. So we should try to keep the missions as short as possible to get the patients off the ground and to their final destination, to the hospital. So this is what we carry with us. This is our equipment. We have these 50 millimeters and 100 millimeter Sonoplex needles. I don't get paid for that. So we have sterile probe cover and sterile gel. And this is what we found when we did the blocks outside in the winter. We have these self-adhesive probe covers, which are great when we use them in the hospital, but at low temperatures, or temperatures below the, 0, they don't stick. So this is absolutely useless. This is what we found out when we used them in winter. We have two pairs of sterile gloves, we have a disinfection spray, and we use 1% of mepivacaine as a short or intermediate acting local anesthetic. We will discuss that later. Now, a selection of blocks which have shown to be feasible and safe outside. Our interscalene blocks for shoulder dislocations, and shoulder dislocations, you all know, are very painful patients. If you want to treat them with systemic analgesics, for example, with strong opioids, they need a large amount of opioids, and you never get them pain-free. 5 cc's of 10 cc's of local anesthetic, of a short or intermediate acting local anesthetic, another 5 minutes, and then are completely pain-free. And extrication and retrieval with a dislocated shoulder, especially in an aircraft, in a small helicopter, is not very comfortable if you are in severe pain. Supraclavicular blocks have also been carried out outside in the field. Axillary blocks. Maybe one of the most frequent performed blocks outside is the fascial block, or I prefer the femoral. I will discuss that with you later, and as well as distal sciatic nerve blocks. And now, what is current status across emergency medical systems, and what is the evidence behind pre-hospital regional anesthesia? So in the past, all these techniques have shown very high success rate compared to systemic analgesia, especially for upper limb blocks, interscalene, supra and infraclavicular, but also for femoral sciatic nerve blocks. And they have been used for all patterns of injury, and they are significantly superior to systemic analgesia, which could be shown in quite recent publications. And even more when we go into austere environments, medical teams that are on expeditions. There is a nice scoping review. I put together randomized controlled trials or trials, case reports, case series, and put all the information together. And they found that even under extreme conditions, regional anesthesia was feasible, even without ultrasound. We should not forget that fascia iliaca compartment lock was initially a blind technique developed for emergency physicians. So even in these extreme environments, interscalene blocks have been performed, infraclavicular, also digital nerve blocks to treat frostbites, which is a common type of injury during high altitude expeditions or polar expeditions, for example. Interestingly, and this is an ongoing source of debate, that who can or who should be allowed to provide regional anesthesia in the field. And there's difference across Europe concerning different providers. In Austria, Germany, Switzerland, and in Italy, these are physicians, mainly anesthesiologists, emergency physicians, surgeons. But we know systems also in Europe where paramedics, specially trained paramedics, for example, in the Netherlands, or nurses, are trained to do, for example, fascial iliac blocks. And even astronauts have been trained to do nerve blocks in space. So yeah, let's see where systems will develop, but this is the situation in Europe. The German-speaking countries are physician-staffed systems, but there are differences, differences in RA providers, which nevertheless which show also good results and work with great success. And when we come to the topic of pre-hospital nerve blocks, there are always areas of concern. And this is a major topic when we talk about pre-hospital blocks. It's always the question about what about nerve injury, LA toxicity, what about infection controlled, what about bringing a patient to hospital with an anesthetized limb, and how do we obtain informed consent from a patient? So the question about nerve injury, if the blocks are performed with the proper technique, with proper training, so the incidence of nerve injury should be the same as in hospital, and we know that the overall incidence of our nerve blocks is very, very low. The problem arises when the nerve injury is a result of the primary trauma. But this is the reason why we do a good documentation outside. We check sensory and motor function as good as we can, and that we use short or intermediate acting local anesthetic to have the block wearing off in the hospital for a follow-up assessment of neurofunction. Infection control is also an ongoing debate. I have a slide on that. The anesthetized limb, as I mentioned, we use short and intermediate acting local anesthetics, so we want the block to wear off within 2 or 3 hours. Some systems, they had the chloroprocaine, but as far as I know, this is not marketed anymore in Austria. I don't know what's the situation in Europe, but we don't have the very short acting local anesthetic anymore, which is a bit of pity. And informed consent is always difficult to obtain in a patient with who is in severe pain. But let's go through that points. So what about local anesthetic toxicity? We use low volume blocks. We all know that a successful interscalene block can be performed with a volume of 5 to 10 mLs of a local anesthetic. Another 10 mLs for femoral nerve block for good analgesia outside in the field. And this is my advice, use safe drugs. Safe, what means safe? There is no safe drug, but we know that the safety profile for lidocaine is much better than, for example, compared to bupivacaine or ropivacaine in terms of systemic toxicity. And don't use long-acting drugs, use intermediate or short-acting local anesthetics for pre-hospital nerve blocks. So what about infection control? There has been a recent update of the practice guidelines of infection control of the German Society, which I find one of the most useful updates in the field of regional anesthesia. Because what they say is that hand hygiene is even more important than wearing examination gloves. We all know that examination gloves are not very, that the quality differs very between manufacturers, between one piece to another. So the most important part is hand hygiene, skin preparation. We use a sterile probe cover, we use a sterile gel, and the no-touch technique. And this is the same as we do the blocks in the hospital. For single-shot nerve blocks, this is hand disinfection, hand hygiene, examination gloves, sterile probe cover, sterile gel, and the no-touch technique. And this are the same requirements for infection control outside. Nothing less and nothing more. So what about informed consent? What I do is I always inform patients about the possibilities. I always tell the patient we have the possibility of systemic analgesia, which in a certain situation, of course, provides analgesia, but never makes you pain-free. And we have the possibility of nerve block. That means that we do some injection in your neck or in your groin area. And after another 5 to 10 minutes, you will feel a significant reduction in pain. And of course, it's very important always on the basis of a risk-benefit ratio. We don't do pre-hospital blocks just for fun. It has to make sense to the patient, and it must be of additional value on that mission, because it's a difficult retrieval, it's a difficult extrication. Sometimes we do have a situation, especially in the Alps, with rapid changing weather conditions, that we have to stay with the patient, for example, 4 hours. and we don't get a retrieval by air because the helicopter is grounded or needs to get back to the base because of rapid changing weather conditions. And there we have to have a good plan for a longer lasting analgesia. Documentation is mandatory, as well as a very good handover to the hospital. Tell them that you have done a nerve block. Tell them that there must be an anesthesiologist involved to have a second look on the patient. That is very important. A good flow of information to everybody that's involved, who is involved in that case. So, what is my perspective on pre-hospital blocks? We all agree, and that's what we have learned from our cases, that it's absolutely safe, that it's feasible, and that many other systems should promote this kind of analgesia outside in the field. We know that it needs additional training and education. And what we saw in the past, that the protocols we use in hospital, that not all meet the requirements outside in the field. If you do these rescue missions and retrievals, sometimes we need to be a little bit creative. So those of you who are also serving as emergency physicians, they know what I mean. Every mission is different, every patient is different, and sometimes yeah, we need unique solutions outside. But for these very painful injuries, pre-hospital blocks are of a very, very great value. Now let me summarize. Despite we use pre-hospital blocks regularly in hospital, regional anesthesia is still underused in pre-hospital care. We now have a absolutely new generation of handheld ultrasound devices, which are of great value, which provide brilliant ultrasound images. And as I mentioned many times, we can provide optimal analgesia with nearly no side effects, and the blocks are safe. But we should not forget that the pre-hospital blocks are challenging due to environmental factors. We don't have the same staff as in the hospital. Patients are in different positions. They are on the ground. They are in some other positions due to their accidents, etc., etc. And it's absolutely nothing for beginners. We need to set up protocols for training and to bring these mode of analgesia forward outside in the field. So this is the end of my talk now, and I am looking forward to a exciting discussion with many colleagues who were listening to this webinar.
Yes, we have a lot of questions. So the first one is from Kevin. Should nerve injury be a contraindication for nerve block? Keyword double crush phenomenon.
Yeah, but we should not change our approach. So when I see a patient in hospital with a nerve injury, we don't have good data on that. Double crush is a theory, but in a case like this, to be honest, I would not do a regional block outside in the field. If a nerve block is that obvious, I wouldn't do that. So that's my approach to a patient with a trauma-related nerve injury. It's the same as in the hospital.
The second question that we have, thank you very much, it's from Peter. Do you prefer lidocaine or marcaine?
Lidocaine is one of the oldest drugs. I think it's the oldest available in the moment, and it's regarded as safer. I mean, no drug is 100% safe. It depends on of course we all know dosing, etc., etc. But I tend to use lidocaine because we also have lidocaine with us for other subcutaneous infiltrations, etc., etc. And it's also our local anesthetic. At the moment, we use mepivacaine, but I think for the future we should stay with the lidocaine. That makes absolutely sense.
Thanks. After we have another question from Yoti Gupta. Do you advise diluted local analgesic or undiluted for the regional anesthesia?
We use it undiluted because with every process of diluting medications outside, as I said, we are sometimes operating in difficult environments. It's windy, it's cold. Um, so I use pure solutions, 1%, no mixing, no dilution. It's not necessary. Keep it as safe and stupid as possible. And if you are outside in the field, you have several syringes, you have to do the correct labeling. So that's what I also do in the hospital. I like pure solutions. Keep it safe and stupid.
Have you ever tried the combination of fentanyl and esketamine without midazolam?
No, I've never done that. Whether I use opioids or I use ketamine, but I've never combined them both.
Did you experience did you experience toxicity in your practice? Yes, you speak about this about in your presentation, but there is this
I'm
question from
I'm I'm doing blocks now for 25 years, and I remember one case which I did a lumbar plexus block, psoas compartment block, which is a high volume block. And after 5 to 10 minutes, the patient developed slurred speech, tinnitus, tachycardia. It was delayed absorption of local anesthetics. And interestingly, a few weeks ago, we had a patient after femoral triangle block. She received a knee replacement. But all these blocks, what they all have in common, we use a much higher amount of local anesthetics. For analgesia, especially for upper extremity interscallions or femoral nerve blocks, you can provide good analgesia with volumes of 5 to 10 mils of local anesthetics. You don't need to inject 20 cc's of local anesthetic for a femoral nerve block. And for me, blocks like an erector spinae block, which is very fashionable at the moment, or other high volume blocks, that's what I would not do outside because it requires a large amount of locals. So keep small amounts, precise, tailored to the nerve to have good analgesia.
Another question. Would pre-hospital anesthesia and nerve blocks not affect the primary hospital assessment and also when being reviewed by the specialist team?
But this was also when I studied medicine, when I went to medical school, and when I started to work as a young resident, as a trainee, surgeons said they don't want patients with acute abdomen to have opioids because they simply cannot assess patients. I mean, we live in the area of high quality medical imaging. So we have uh, sonography, we have CT, we have MRI. So this is the basis. This is the still the basis of diagnostics. And of course, but that's the reason why I use short or intermediate acting local anesthetics as the lowest volume to have the block wearing off as soon as possible. But for example, if you treat a patient with a fractured hip or with a fractured femur, there is normal in a fracture like this, there is no need for neurological assessment. So the need for neurological assessments is mainly for upper extremity fractures or for complex fractures of the lower extremity. And there, when you use lidocaine, it wears off after 2 or 3 hours. And what is the consequence? That's what I was asking. What is the consequence? So there is no need for immediate medical intervention, and we are not talking about compartment syndrome. There are certain situations, lower limb fractures, lower leg fractures where I would not do a block. So, but especially for hip fractures, femur fractures, and upper limb injuries, it's the best analgesia we can have. And I mean, it's a core responsibility to provide analgesia, nothing less and nothing more.
Do you have any data in regard of success in infection rate and complication rate, including last toxicity, when comparing pre-hospital versus hospital regional anesthesia?
So the data that I've published so far, they show the same safety profile as compared to hospitals. And to be honest, I've never seen, as long as you do not inject the local anesthetic intravascularly, I have never seen last or delay last with these low volume blocks for 25 years. So the only cases I am aware of, I've seen in my practice where these high volume blocks, as I said, lumbar plexus block, adductor canal or femoral triangle block with larger amounts of local anesthetics, but not with these small amounts, as long as you don't inject it inside a vessel.
How do you perform the neurologic examination?
Oh,
The condition of the on the mountains during winter are very difficult. You evaluate major movement and cessation.
Yeah, not more. Move. Can you move your fingers? Do you feel your fingers? Is there any tingling? So there is no, and this is you can't expose the patient. You can fully expose them. So it's the hands, it's the fingers. Can you move the fingers? Do you feel your fingers? And that's it.
Please tell us about a little bit more about the no-touch technique.
No touch means that the needle and the device and the ultrasound probe that they can. Do I still share the screen?
Yes, you are
Okay.
still
You
sharing.
see it in this picture. There is no contact between the needle and the probe. This means no touch.
The informed consent is only verbal.
Yeah.
What is the real legal value? Isn't it implicit when we balance benefits versus risk?
The thing is, who is obtaining informed consent for deep sedation, for the risk of aspiration, and for hypoxemia? No one. And I've seen these cases outside, severe injuries, heavy pain, giving patients opioids, and then they stop breathing, and there is a need for mask ventilation, even for intubation. Who is obtaining informed consent for that? No one.
Perfect. We have a question from Sabrine, a resident in anesthesia. I would like to ask, what do you mean by bone touch technique in terms of infection control? Well,
That's the same.
it's the
I
same.
already mentioned that. That's the same. No touch means that the needle and the probe are not touching.
So there is no infection.
Yeah.
Do
And
you
this is,
sorry.
and to emphasize, this is in line with the updated version of the German recommendations, roughly about infection controlled in regional anesthesia. And the overall incidence of local infection is going to zero after single shot nerve blocks. We're not talking about perineural catheters, single shot nerve blocks.
Do you use nerve stimulation as well?
No,
If not used
no.
regularly, do you carry the equipment for that purpose or not?
No, we
Never.
don't have it. It's pure ultrasound guided.
Okay. Does nerve block mask compartment syndrome how to convince surgeon or MRP regarding the same?
Again, use short or intermediate acting local anesthetics. I've seen patients who developed compartment syndrome under spinal anesthesia with severe pain. So I would not. What we saw, I was in a working for several years in a trauma center. If you do dense blocks with long-lasting local anesthetics like Ropi or Bupi, maybe you can mask it, but not with the short and intermediate acting ones.
We have another question. Thank you for your excellent speech. Do you practice anonyma punction in emergency case, ultrasound-guided outside too?
No, no.
No.
When we don't do central venous lines, if this is meant when we need vascular access, we also use ultrasound to approach and address peripheral veins. We also use it for this, but we don't do central lines outside in the field.
How do you meet the surgeon worry that the block will mask the compartment symptoms?
When I'm in a rescue mission outside in the field, the decision is on me. At that time, there is no surgeon around. So I'm responsible for the patient and I'm responsible for the best quality and analgesia. And then we can discuss that in the hospital. For these dislocated shoulders, they are very, very happy because they receive them pain-free. And this was, for example, also the case yesterday. We did the femoral nerve block. You transfer the patient to the hospital. And this is the big, big advantage because they then, we bring them in on our stretcher. They are then transferred from the stretcher to the examination bed. They go into the X-ray pain-free. And this is what patients love. This is what nurses love. But you have to do a good documentation and talk to the surgeons.
Don't you
But
worry about coagulation test?
no, because all the blocks we do are superficial blocks. No, no, I don't worry. And the recommendations about anticoagulation, for example, or coagulation disorders and superficial nerve blocks, they are quite straightforward. I mean, if you have a patient on anticoagulation with a severe injury outside, with severe bleeding, you have other problems, more problems than only pain. So this is always challenging.
Do you use dexetomidate presedics in regional anesthesia or sedation?
Not outside. We use it for sedation in ICU, but we don't add it as an adjunct. If this is meant, when we use additives, we use IV dexamethasone, but not dexmedetomidine. We use it for sedation in ICU, but not in an emergency setting. As I said, the amount of drugs is very limited because we have not everything we carry with us is limited because it all means weight for us. It means our backpacks are getting bigger and heavier, and so we have to keep it limited. We can't carry everything with us.
What do you think about epidural anesthesia for emergency medical care?
I would not do that. We should not forget that if a patient has complications after an epidural, that means that he or she can end up in a wheelchair. We use epidurals in ICU for certain conditions like acute pancreatitis. We use the epidurals after major abdominal surgery. I used it for pelvic trauma, for major lower limb trauma in ICU, but not outside and not in an emergency setting. We have other methods to provide analgesia. Yeah.
Would you do a scalenus nerve block for dorsal shoulder luxation if it is known as a dorsal luxation?
Oh, that's difficult outside because we don't have X-ray. And what we don't do outside, we don't reduct the dislocations. But unless we are in a difficult retrieval situation that we have to stay with the patient for hours, for example, in a mountain cabin or somewhere else, which is sometimes the situation. But we provide analgesia and that's it. We don't have an X-ray. For example, in winter, especially the skiers. They have lots of clothing, jackets, so you have no idea if it's an anterior or posterior dislocation. So analgesia, and then transfer them to the hospital.
This is a question from Joroslav. Is there any pre-hospital regional anesthesia course available in Europe? Thank you for your interesting lecture.
Yeah, yeah. Thanks for your kind comment. Not so far. We have it at the ESRA. I think we had it in one of the last ESRA conferences. We had some workshops for pre-hospital blocks. But in general, they are not differing from blocks as we do it in our hospitals, and we also do blocks in our emergency departments. But the difference is the environment. So if you would like to train that, use these small devices, get a model or a volunteer, go on the ground, or try to do scanning when the patient is in a lateral position. So this is what these are the challenges. It's the environment. The blocks, the techniques, they are basically the same.
Do you prefer single injection catheter for the blocking trauma patient?
Single injection, we don't do catheters outside because then I would worry about infections. So this is nothing for. I know that military. What I did, I skipped the military part because I have no experiences on that. But that's what military medical services do. They do regional outside in the field with blocks because they have long transport times. They have difficult extrications, they're under enemy fire, etc., etc. Yeah.
Did you do regional blocks in patient with altered consciousness in emergency?
Yes, sometimes I do if it is necessary. Yeah, if it's necessary.
So we have another message. Thank you for the perfect presentation. But what are your guideline in Austria for regional anesthesia in emergency medicine, aka out of hospital? And what if the patient is in no condition to approve or not the procedure?
Okay, so I would answer the second part before. If a patient is not willing to, if there's no possibility to talk about or to explain what we're doing, then I would not do a block because this is then a situation yeah, and it's the same as in the hospital. But of course, I can only imagine a situation where a patient is heavily injured, under severe pain, maybe an amputation injury, or that it's a case by case decision. As long as it makes really sense for the patient, long as you do something good for the patient, you should think about it. And in Austria, at the moment, we don't have a nationwide approach to pre-hospital blocks. It's what we started to practice it in our system, but that's it. There is no national, yeah, guideline or directive on that.
Have you ever come across a situation whereby a neuraxial block would be considered or deemed appropriate, such
Outside,
as
no, I would not do neuraxia blocks outside. In terms, I would really worry about the infection control. I wouldn't do neuraxia blocks outside. Maybe there are systems or situations in which it might be necessary, but not where we do emergency medicine. No, I wouldn't do that.
how common is phrenic nerve involvement doing regional blocks for a traumatic clavicular injury in an elderly PT? How to avoid?
Oh, so the phrenic nerve block as a result of an interscalene is very common. If this was the question, as a result of an injury, I don't know. I have no idea on that. But when we do interscalene blocks, it's just a matter of volume and where we do the block, we can reduce the proportion of or the amount of phrenic nerve blocks when we do this, for example, superior trunk block or use low volumes. Yeah. So I don't worry about that. But what I do worry about is using a large amount of opioids and then having a patient during retrieval where I can't access him because you're using these rescue beds and rescue bags. So the patient is fixed inside, and we have at least a few minutes or a certain period of time where patient access is very, very limited, and we have no chance to interfere or do some interventions.
Do you recommend other blocks for the pre-hospital emergency medicine that you didn't mention in your presentation?
No,
For
what I
example, isolated distal upper extremity nerves.
absolutely you can do if you have foot injuries, which are very painful, you can do ankle blocks, wrist blocks for hand injuries, for frost bites, etc., etc. The more peripheral we go, the safer it is. So, but what I would not do it blocks like, for example, lumbar plexus block, psoas compartment block, neuraxial blocks. But the more peripheral you go, the better it is and the safer it is for the patient. So everything is possible as long as it makes sense.
What are your thoughts on rebound pain?
Rebound pain, we know that rebound pain is a problem, but at that time the block wears off, the patient is in hospital and professionals, healthcare professionals are taking care of the patient. Um, um, and should deal with the problem. Of course, we know it, but rebound pain is more a problem in ambulatory surgery when patients are sent home and they are on their own, but not as long as they are in hospital. And it should be able that healthcare providers, are able to deal with it. I hope so.
Okay, we have other three questions. What about the fracture in the inferior part of the lower limb? They hurt a lot. You didn't talk about them. What are your concerns?
It depends if they are what the biggest challenge for us is to extricate and retrieve a patient with a fracture. And lower leg fractures are, if they dislocated, they are painful, but we manage this with midazolam ketamine because you have to bring the leg in axis. You have to do some kind of reduction and stabilize the injured limb. And once this has been done, pain is not that problem anymore. So in these situations, I felt the need for now for many, many years that there's not really a need for a nerve block. In most instances, it's the fractured hips, femur fractures, and upper limb injuries.
We have I don't know if you can answer, but what is your favorite new generation ultrasound device to use?
Oh, I'm not advertising, but the only thing I can tell you is that the one I've shown you is absolutely brilliant. So if you have the chance to get one to practice a little bit and to test, you should do that.
How many hands, people, do you need to perform a block? One sonoprobe, two needles, three injection?
Yeah, maybe you've seen that in the screen. I trained myself as many others do to have the syringe in the same hand, which is guiding the needle and the probe in the other hand. But it's of course good. We have a paramedic with us on the. We are a team of three. There is one pilot. There is a paramedic and which is also a specialist in rescue, and it's a doctor. So of course, to have a third hand is not a luxury. It's nice to have a person who is assisting in doing everything. We need a person assisting us in intubation, in preparing the meds, securing the airway, fixing the tracheal tube, etc., etc.
Okay, there is another person that asked me, this is the last question, let's say, if you can share your experience, what serious complication you have witnessed from nerve block and pre-hospital analgesia? A new experience that you didn't.
Pre-hospital analgesia, and I remember a few cases who were patients, they were under severe pain. One young 16-year-old girl, she had a severe pelvic fracture. She was a skier, a terrible crash. She was crying, NRS 10. It was an open book fracture. And she had lunch 30 minutes prior to her accident. And we used fentanyl, and then she stopped breathing. She was she was deeply sedated. She was pain-free. And I was surprised because the amount of fentanyl I gave her was not that big. It was the same as I would use in hospital for analgesia. And she stopped breathing. I was really a bit frightened of that. And then we needed the bag mask ventilation. And then we decided to intubate the airway. So whatever we do outside, emergency medicine is always carries a certain risk. But in trauma, it was always the patient who started. It was not us, it was the patient who started, and we have to solve the problem. That is the thing.
Well, there is another more question. There are other questions, but let's say
Yeah,
that
I see them.
this is the last one. And
Yeah.
one more question. Do you perform peripheral nerve blocks on children in pre-hospital care?
I've never done one pre-hospital in a kid, but I do them in emergency settings in hospital. We do that because it works pretty well. We do femoral nerve blocks, especially in winter. We see young teenagers, we see kids with fractured femurs, but I've never done one in a kid outside in the field. But I would do if it's necessary, of course.